Hey guys, welcome back to my channel. So today in this particular session we will be talking about a very important topic, that is Guillain-Barré syndrome from the neurology, right? So basically they say that this is Guillain-Barré syndrome, this is AIDP, right? Now what do I mean by AIDP, right? AIDP means that is acute inflammatory, right? This is acute inflammatory demyelinating. So here one thing is clear, that we will be talking about the demyelination, right? So basically demyelination is happening in this particular syndrome, demyelinating polyneuropathy, right? Polyneuropathy, or you might say polyradiculoneuropathy. Okay, so multiple neurons will be involved over here if we are talking about the Guillain-Barré syndrome. However, this is one of the type of Guillain-Barré syndrome where we are talking about the AIDP particularly, right? So I'm just highlighting this point, and if you remember this point, you know, almost 20% of the job is done as far as this topic is concerned. So AIDP, this is the acute inflammatory demyelinating polyradiculoneuropathy. So basically this disease is also autoimmune kind of disease, where we will be talking about some autoantibodies. However, they are forming against the antigens, and how they are actually damaging the neurons. Basically they are damaging the myelin sheath of the neurons. We'll get to know about that. So guys, basically these kind of patient, when you will be seeing these patients in the casualty or the emergency, they will not be having a very long history, right? So usually they are having a short history and not more than 1 month, right? So the symptoms will be starting from maybe 1 or 2 weeks prior to the presentation. So for example, they are presenting to you right now in the emergency, so the symptoms which they will be talking about, they will not be giving a very long history. So basically in most of the cases they will be telling their symptoms that from past week or from past few days they are having these kind of symptoms. What are the presentation, okay, what will be the features, we'll get to know about that very soon. So basically this is the acute inflammatory condition where we will be seeing that demyelination is happening. The neurons are not very healthy over here, right? So both kind of neurons can be involved, guys. Motor neurons can also be involved, and the sensory neurons can also be involved. And you know that if both the neurons will be involved, that I mean the motor and the sensory, then the prognosis will become poor, obviously, right? So that is the case over here. What kind of age group I am talking about? If I am talking about this particular syndrome, then I am talking about the middle age group, right? For example, about around 40 years of age, that is the age group where we are talking about that most of the patient might present to the casualty, right, with this kind of syndrome, right? So not a very long history, right? Secondly, I said that the important point, that what is the age over here which I am talking about. So almost around mean age would be around 40 years, right? So age, if I am talking about, around 40 years, right? That will be around 40 years. Which gender I am talking about? Generally there is no discrimination, but it has been seen that usually the males patient are more as compared to the females, as far as this GBS is concerned. Guillain-Barré syndrome, in short, we are calling that as GBS. So usually, however, females can also be affected with this particular syndrome, but usually it is male more than females, right? Now let's talk about some of the types, guys. Let's talk about some of the types. So here, this is the GBS, right, Guillain-Barré syndrome, and we are having some types. We can see some types. Basically 4 important types has been recognized as far as this syndrome is concerned. And what are these types? So first of all, we have talked about, this is the acute inflammatory demyelinating polyneuropathy. This is the most common type where we are seeing in the patient, that is the AIDP, right? And here let me just summarize the types first of all, then we will get into the details. So then second type is the AMAN means that is the acute motor axonal pattern. Acute motor axonal neurons, they are involved over here. So I said they are the motor neurons. They are the motor neuron. If I will be adding sensory to that, then it will be the AMSAN. So acute motor sensory pattern, if it is there, then it is involving, I mean both the neurons are involved, motor and sensory. Basically the axonal sheath is involved, so axonal part is involved of the neuron, so that becomes AMSAN, right? That becomes AMSAN. And the next type is the Fisher syndrome, or we are saying that Miller-Fisher syndrome, right? So that is the Miller-Fisher syndrome, right? That is the Miller-Fisher syndrome. right? Now I told you guys that this is the autoimmune disease, this is the autoimmune syndrome, autoimmune condition. So here we are talking about the autoantibodies, right? So with these different types we shall talk about the different autoantibodies. Sometimes they might ask us in the exam, and it is good to know about these kind of autoantibodies as well, right, at this point of time. So if I talk about the AIDP, this kind of type is having the anti-GM1 antibody, right? So let me just write it over here itself. So AIDP is involving the anti-GM1 antibody, right? So I'm just writing like this, right? And as far as Aman is concerned, then it is involving the anti-GD1A antibody. This is involving the anti-GD1A antibody, right? Okay. And as far as Miller-Fisher syndrome is concerned, then it is involving the anti-GQ1B antibody, right? This is involving the anti-GQ1 antibody, right? And if you talk about the Amsan and Aman, they are usually sharing the common autoantibody, right? Now one more thing that guys, if the motor and sensory, both the neurons will be involved, okay, so then obviously the prognosis will be poor. So with the Amsan type of GBS patient, obviously they will be having the poor prognosis because both motor and sensory neurons will be involved over there, right? Okay. Miller-Fisher syndrome, guys, a typical triad is seen in the Miller-Fisher syndrome. So please do remember that triad. So let me just summarize that triad over here itself. That in the Miller-Fisher syndrome, we are seeing the ophthalmoplegia, right? Ophthalmoplegia, right? We are seeing the triad, ataxia, and we can see that there would be the areflexia, right? So the responses or reflexes, you will be checking the reflexes, right? Usually if the patient, neurological patient, if the patient is coming to the casualty, right, and we are doing the neurological examination, so one of the part of that examination to check for the reflexes as well, right? So you are checking the knee jerk reflex or the ankle reflex or the bicep reflex or the right, so different kinds of reflexes are there. So these reflexes will be very, very poor. The reflex response will be very poor in these kind of patient, right? So areflexia or the hyperreflexia might be seen. So ophthalmoplegia, ataxia, areflexia, this is the triad of the Miller-Fisher syndrome, which is one of the type of the GBS, right? Then Miller-Fisher syndrome, guys, it is having which antibody involvement? That is the anti-GQ1 antibody, which we have talked about, right? And what is the most common type of the GBS? Then I told you already that most common type is the AIDP, that is the acute inflammatory demyelinating polyneuropathy, where we are seeing that secondary axonal degeneration is seen, right? Now if I talk about the pathophysiology over here, if I talk about the pathophysiology, then it is not very clearly known by us, but what we know is, let's try to find out. So what do we know from the books? That there is some unknown antigen, right? There is some unknown antigen, and against this antigen the antibodies are formed. Which antibodies are formed? Obviously they are the autoantibodies, right? I am just writing like this. So these are the autoantibodies which are formed against this antigen, right? Against this antigen, and then what happens is that they will be binding to the myelin, they will be, right? So this is structure over here, right? This is structure over here, it will be actually binding to what? It will be binding to the myelin, right? As it will be binding to the myelin, they will be forming a membrane attack complex. As they will be attaching to this myelin, they will be forming a membrane attack complex, right? So very important, guys, they will be forming a membrane attack complex, right? As they will be forming the membrane attack complex, this membrane attack complex, MAC, it will be actually bind to the surface of the Schwann cells. It will be binding to the surface of the Schwann cells, right? Everybody knows what is Schwann cells. They're the part of, yes, neuron, right? So look over here. So Schwann cells will be involved over here, and as they will be binding to Schwann cells, they will be destroying the myelin. So myelin will be destroyed. So myelin will be, right, destroyed over here, isn't it? So this is the myelin sheath which you can see over here. This is the myelin sheath, right? This is the neuron, this is the neuron over here, and myelin sheath is covering that. Between two myelin there is a node of Ranvier. We already know that, right? So what happens? Node of Ranvier, okay, we know that from the physiology and all. So guys, what I'm saying is that this membrane complex will be binding to these Schwann cells, and you can see that this has been disrupted, right? So myelin has been disrupted, so this is called as a demyelination. That's how we are calling this as acute inflammatory. This is the acute condition because the history is not very long. The patient will be talking about the 2 or 3 weeks history, right? So it is a recent history. This is acute condition, so acute inflammatory demyelination is happening. So demyelination because multiple neurons are involved, so that's why polyradiculoneuropathy. I hope this part is clear. So Guillain-Barré syndrome, this is a GBS. L is silent over here, affects the nerves in the brain and the spinal cord. I hope this part is clear till now, right? Okay, let's move on guys from here, and let's talk about what would be the presentation in these kind of patient, right? So I hope you are enjoying till now. If you are enjoying, then please do hit the like button, and please share your views in the comment section too, right? So presentation guys, if you talk about, then it is causing the ascending kind of symptoms, right? Or I would say it is causing the ascending manner or ascending type of paralysis, right? So basically the symptoms will be starting from the lower limbs, from the legs, and then it will be ascending upwards toward the trunk and the upper limbs basically. Okay, so over here we are saying that history will be not very long, history will be shorter only, and usually the symptoms will be starting from the legs of the patients or the lower limbs of the patient, right? In the legs they might actually complain about the tingling sensation, right? They might complain about the tingling sensation in the lower limbs, right? They might when you will be examining the patient, you might be seeing that the patient might be having the areflexia, or the patient might be having the very low reflexes response, right? So that could be the complaint over here, right? So it is the rapidly progressive ascending paralysis. So these kind of patients are actually showing rapidly progressive ascending paralysis, right? Rapidly progressive ascending paralysis. As I told you that the symptoms will be starting from the lower legs, the rubbery kind of sensation will be there, tingling sensation will be there in the legs, and gradually it will be ascending upward. So rapidly progressing ascending paralysis, right? So that is the case over here. Reflexes will be on the lower side, so low reflex response might be seen over there, right? Okay, both motor or sensory neurons can be involved, but if they will be asking you what kind of cranial nerve involvement can be there, however not many cranial nerves are involved, but at that point of time you can say that either the seventh nerve, which is the facial nerve, or the oculomotor nerve, that is the third nerve, seventh or third nerve involvement might be seen over there. Seventh or third nerve involvement, right, might be seen in the GBS patient. Okay, so that is also a point which we need to remember over here, right? Okay, so if I'm talking about the ascending paralysis, then basically it starts from the lower limb and then it will be ascending upward toward the upper limb. So proximal and the distal, both kind of weakness might be seen in these patients. So even the proximal plus distal, both kind of weakness we can see, right? So both kind of muscular weakness we can be seeing in these kind of patient. This is the diagram guys, where we can understand that the the symptom will be starting from the hands and feet, and basically start from the feet only. So we begin to have the tingling sensation, right? So basically it will be starting from the feet and then it will be ascending upward in this manner, right? So muscle weakness sets in the both sides of the body. So we will be seeing that there is a symmetry pattern, there is a symmetrical pattern will be seen over here, right? Symmetrical ascending pattern, right? Okay, so difficult to climb stairs or the walk, these are the symptoms, right? And at last, that because the this is the ascending paralysis, and sometimes the patient will be complaining of dyspnea or difficulty in the breathing pattern. So within 2 weeks around, the respiratory system could become paralyzed as well, right? So that is also the case which might be seen in some kind of patient, right? So I hope you are enjoying the session, and till now we are clear with these kind of things, right? So to rule out these kind of cases, whoever are having respiratory breathing problem, so we need to do we shall go for the spirometry as well. We will come to that, but right now I'm talking about the presentation part. So this is the presentation which is seen over here, and usually many patients, they recover also. So this is the acute condition, history is not very long, and usually after that the patient recovery is also happening in the rapid manner only. So most of the patient, they might recover in around 2 to 4 weeks, right? So recovery begins very soon over here. So recovery might happen in around 2 to 4 weeks, right? 2 to 4 weeks the recovery might be seen in many patient, right? But not all the patient, I said many patient. Okay, in some kind of patients we have seen that there are the autonomic nervous system fluctuation. There are the autonomic nervous system fluctuation. What do I mean by that with the autonomic nervous system fluctuation? I mean, there are some patient where we can see that there is a fluctuation in the blood pressure, there might be the fluctuation in the heart rate pattern. So there might be the arrhythmias in some patient as well, right? There might be the arrhythmias in some patient as well. So whenever we are examining the patient, we should know these kind of things might also happen in some kind of patients, right? So this is the ANS fluctuation which might happen in the patient. Now what could be the etiology? You might be thinking, what could be the etiology, what is the trigger point? So what is the triggering agent over here which might be causing these kind of symptoms in the patient, right? So let's talk about the etiological agents which are actually seen to cause these kind of symptoms in the patient, that is the GBS, right? So guys, if I talk about the triggers, or if I talk about the etiology, right? If I talk about the etiology or triggers, whatever you say, then here we are having some very popular examples, and most of the time they are actually tested by the examiners as well. So guys, one is, so this list we need to remember. So one is the Campylobacter jejuni, right? Campylobacter jejuni. Another one is the Epstein-Barr virus, right? Or cytomegalovirus, right? Or mycoplasma can cause this, right? Hepatitis virus can cause this, or which subtype? Hepatitis A, hepatitis B, right? Even the HIV can be causing this. But what is the most important one? Campylobacter jejuni, right? If they want to ask you the trigger agent of the GBS, right, if they want to ask you, then most probably it has been asked also multiple times. So Campylobacter jejuni is the thing which we need to remember over here among all the causes, among all the triggering factor, right? Once we are clear with that, we shall move on to the diagnostic criteria, that what could be the diagnostic criteria over here, right? So for the diagnosis part, guys, because I told you that this is ascending paralysis, we are seeing that ascending paralysis is happening. So respiratory pattern might also be getting disturbed, and the patient might be having the breathlessness as well in some cases. So for that purpose, we shall go for the spirometry in those cases where the patients are complaining about the breathing pattern problem, or the chest pain problem, or like that, right? So the spirometry might be done in those cases, right? However, in these cases we are not doing the LP, we are not doing the lumbar puncture. So if we need to do the lumbar puncture, or that is the LP, so in those cases, what would be the finding? Okay, this has been asked earlier as well. So albumin levels will be disturbed. So albuminocytologic dissociation is seen, right? This is very important term, right, which has been asked previously in the exam. So that is the thing over here. It means that albumin levels, or the protein levels, they will be increased in the body, right? So they will be increased, and however WBC count will remain normal. That's why they say that albumino means albumin, and cytologic means WBCs. Cytology means cyto means cell, which cell? WBC cell. So albuminocytologic dissociation is seen. It means that albumin will be on the lower side, and cyto means WBC will be albumin will be on the higher side, right? And WBC will be on the normal range, right? So that is the albuminocytologic dissociation. However, in every patient, lumbar puncture is not needed. Even with the spirometry, every patient do not need the spirometry as well, right? In some patient we shall go for the nerve conduction studies. In some patients we shall be going for the nerve conduction studies as well. Yeah, so nerve conduction study, because we know that the neurons are involved over here, so nerve conduction study can be done. Okay, so for example, what could be the finding? Slowed conduction velocity can be seen over there, or the amplitude is reducing in the nerve conduction study. These kind of things might be seen over there. Okay, now what is the treatment part over here? If we talk about the treatment, okay, if we talk about the treatment part is not very tough, but at the same time it is expensive. All right, so not every patient can afford that. So we are having two options over here. I would be writing it like this rather. So treatment, we are having two options over here, right? Either the patient can go for the IVIG, that is the intravenous immunoglobulins. Either the patient can go for this IVIG, either the patient is having the option for the plasma exchange, or we say that is the plasmapheresis, right? Plasma exchange or plasmapheresis, right? So the patient is having two options. However, it is seen that IVIG, both are equally effective, but it is seen that IVIG is slightly more effective, but some people, some doctors believe that, but in the books and all, it is having the equal importance, both of them, right? If we talk about the IVIG, basically IV immunoglobulin, if you are giving, what is the dose over here? 0.5 gram per kg, 0.5 gram per kg for 5 days, right? And if we talk about the plasmapheresis or the plasma exchange, we are basically doing we can go for the 5 cycles, right? 5 cycles has to be done, and that is the minimum 5 cycles need to be done for this patient. Plasmapheresis is also not very cheaper, right? So not every patient can afford that, right? So IVIG or either the plasmapheresis, that is the case over here. So how this patient will be presenting to the emergency, right? So once we have recognize the disease, once you have understood about this, so now let's try to approach this patient. So let's say you are in the casualty, so this patient is presenting to you. How the patient will be presenting, right? So let's find out. So a 35-year-old man is there, and right, I told you the mean age is around 30-40 years. So presenting to the emergency, and the complaint is the department for the difficulty with the walking, right? So legs are involved, lower limb is involved. His symptoms began approximately 1 week ago. So not a very long history. So and has progressively worsened. So progressively worsened. I told you ascending paralysis is seen in this kind of patient. He has noticed some lightheadedness also with standing up from a seated position. Orthostatic hypotension. I told you ANS fluctuations are seen. That is, the patient might be having the fluctuations in the BP. The patient might be having the orthostatic hypotension. The patient might be having arrhythmia as well, fluctuations in the heart rate. Okay. So here the main point is the orthostatic hypotension. I wanna mention orthostatic hypotension, which shows that we are talking about ANS fluctuation, isn't it? Now let's move further, let's read further. And some numbness in the bilateral lower extremity, so legs are involved. Physical examination is notable. You did the neurological examination, and you found out that for the neurological examination is notable for 4 out of 5 power, and decreased the sensation to light touch and pinprick in the bilateral lower extremity. So hyporeflexia or areflexia might be seen. Absent patellar and the ankle reflexes, yes, areflexia might be seen. Lumbar puncture is performed over there, and they found out that demonstrate a cell count of 1 per microliter. Protein is 135 and glucose is 65, right? So I told you the proteins will be on the higher side, right? So what is the summary from this particular question, from this particular presentation? Don't see this case as question, but see this case as a real patient. So the real patient came to you, and so what are the important points? Okay, let me summarize the points over here, what I have learned from this particular patient, right? So first point, I learned that the age over here is the 35 years old patient, right? Second point which I learned, that is the patient is having difficulty in walking, so the lower limbs are involved over here, right? Third point which I came to know, that history is not very long. So third point, history, right? History is not very long, history is short only. Fourth point which I came to know, that is the ascending paralysis feature is there. I mean, not ascending paralysis, but progressively it is weakening. So that is the thing. So fourth point, I would say the ANS fluctuation. that is the orthostatic hypotension, ANS fluctuation, right? Fifth point, I came to know that the patient power is actually getting decreased and the patient reflexes are getting on the lower side, so areflexia, right? Areflexia, right? And third and sixth point, which I shall mention, that on LP there is a albuminocytologic dissociation, isn't it? So these are the points which I can conclude from this particular case, right? And this particular case, if I am talking about, all these symptoms are actually you know, telling us that patient might be having the Guillain-Barré syndrome, GBS, right? I hope you you know, you are able to make out these kind of points. I am just highlighting these points as well over here, right? So let me choose a different color right? So yes, let's choose this color over here right? So 35-year-old man presenting with the difficulty in the walking right? And history is not very long. Symptoms are progressively weakening. Standing up from a seated position, felt lightheadedness, orthostatic hypotension, I mean that is the ANS fluctuation, numbness in the bilateral lower extremity. There was a decreased sensation to light touch and pinprick in the bilateral lower extremity, absent posterior and ankle reflexes, that is the areflexia. Lumbar puncture was done. It shows the cell count of 1 and protein is elevated. Albuminocytologic dissociation is seen, concluding that this patient might be having the Guillain-Barré syndrome. So thank you so much for listening to this session. I hope you enjoyed. If you did, please leave your reviews in the comment section, and I will be seeing you in the next one. Thank you.